Good afternoon, everybody. It's just gone 4 o'clock, so I hope you can all hear me. Geraldine, if you can just let me know if you can hear me.
Perfect, Tanya, you can go ahead.
Great, thank you. So welcome, everybody. My name is Tanya Glatt. I work at the South African National Blood Service, and I'm very excited today to chair a very interesting and special session in transfusion thresholds in therapeutic apheresis. We have two very exciting international speakers, which I will introduce to you shortly. So today's deep dive is brought to you by Blood SA and by the South African National Blood Service in strategic partnership with both the South African Clinical Haematology Society and the South African Stem Cell Transplant Society. I firstly really want to thank the Deep Dive management team for this opportunity and for all of that you do for transfusion and haematology in South Africa. Firstly, Prof. Estelle Verburg as the team lead, Dr. Geraldine Kritzinger as the National Training Coordinator, and Dr. Nicole Smith as the National Outreach Officer. Us in South Africa are really lucky to have this platform where we can all learn from each other and collaborate. So thank you. I know a lot of hard work goes into all of these sessions behind the scenes. There's a few housekeeping notes. So firstly, all of our sessions are recorded. If you go to the website, bloodsa.org.za, and you go to resources and deep dive, you'll be able to find all the recordings. We also really value interaction. So please feel free to add any questions or comments to the chat box during the talk, and we will respond to them at the end of the presentation. So we will have a question and answer session at the end. For CPD points, this is CPD accredited, so CPD points will be submitted to the HPCSA for everybody that has registered. In order to get your CPD points, you have to attend with your own registered Zoom link and not in a group. You need to attend for at least 1 hour, and you need to enter your HPCSA number correctly. If you have any queries about your CPD attendance certificates, you can email admin@bloodsa.org.za. You can also join our mailing list via the website. So if you go under resources and subscribe to Deep Dive, you'll be able to join the mailing list. Otherwise, you can scan the QR code on the right. And we also value your honest feedback, both Blood SA and the speakers. So there will be an anonymous feedback survey at the end of the Zoom meeting. Please, can you complete it for us? Okay, so I'm going to start off today. The topic of our talk is transfusion thresholds in therapeutic apheresis, results from a survey and a focus group discussion. So this will be presented by Dr. Carl Annan and Dr. Jensen Cohen-Sullivan, who I have the pleasure of working with and learning from in the AABB working group. Then we will have some question and answers and closing. So we'll start with our first speaker, Dr. Carl Annan. She is an associated professor of pathology at the University of Colorado Anschutz Medical Campus and the medical director of apheresis and cellular therapy at the Children's Hospital, Colorado. She's a recognized authority in pediatric apheresis, cellular therapy, and transfusion medicine, with clinical oversight of therapeutic apheresis, stem cell processing, and donor center operations. She has authored over 30 peer-reviewed publications in journals, including Transfusion, Journal of Clinical Apheresis, and Clinical Infectious Diseases, and she's contributed to key reference texts such as Therapeutic Apheresis, a handbook, and Pediatric Transfusion, a handbook. She serves as the Associate Editor for the Journal of Clinical Apheresis and holds national leadership roles, including the chair of the AABB Therapeutic Apheresis. That's where I know her from. And the Transfusion Practice Subcommittee and chair of the ASFA Clinical Applications Pediatric Subcommittee. So welcome, Carl, and we're very happy and honored to have you. Our second speaker is Dr. Jensen Cohen-Sullivan. She is a board certified in clinical pathology and transfusion medicine, and she serves as the director of Cellular Therapies Laboratory and of the Transfusion Medicine Fellowship at the University of Michigan in the USA. Her research focuses on medical and procedural antibody desensitization in transfusion and hematopoietic progenitor cell transplantation, and on quality and regulatory aspects of biotherapies. Outside of medicine, she has lots of interests. She loves reading old mystery novels, playing the piano, and aerial fitness. So thank you, Dr. Jensen. And really welcome to the two of you. Thank you. I know that it is 4 o'clock in the afternoon for us, but it's very early in the morning and you've still got the whole of Monday ahead of you. So thank you for your time. And before I hand over, I just want to tell everybody about next week's topic, which is brought to us by Takeda, and it speaks on the safety and efficacy of APCC for the management of bleeding and surgery in hemophilia patients. So thank you very much. And Carl, you please go ahead and share your screen. Thank you.
All right. Do you have the slideshow in presentation mode?
We see
Excellent.
it.
Okay.
It's perfect.
Great.
You can go ahead. Thank you.
All right. Well, thank you so much for the invitation to speak this afternoon for you and this morning for us. Dr. Cohn-Sullivan and I have been working on this project along with many members of the Therapeutic Apheresis Subcommittee for ABB for a while, and we're excited to present the results of this topic. It is a manuscript in preparation. Hopefully it will be submitted very soon. So we're going to be talking to you a little bit about transfusion thresholds in therapeutic apheresis. And so this was 2 parts, a survey and a focus group discussion. There we go. It wasn't advancing. All right, so just a little bit of a background in therapeutic apheresis. I know maybe not everyone on the call is well-versed in therapeutic apheresis. So what it is removal of the patient's blood volume incrementally in order to remove a pathologic substance and or replace a beneficial substance. It is generally safe and well tolerated. And so there's variations in a lot of nuance with this device. One of the main decision points is actually to decide what you're going to replace with, replacement fluid wise, and then how often you're going to perform this procedure. And this is going to be based on, for example, what the underlying pathology is. So our kind of hallmark disease for therapeutic apheresis, the one that's even made it into TV shows like Scrubs, is thrombotic thrombocytic purpura, or thrombocytopenic purpura, which is also difficult to say. I'm going to say TTP for the rest of the meeting. And so this is a disease that has an 80 to 90% fatality rate without urgent treatment. And in a randomized controlled trial, plasma exchange with replacement of FFP was found to be superior to simply plasma replacement. And the reason for that in this particular disease is that the disease is where there are very large von Willebrand factor multiples, and they end up causing a thrombotic microangiopathy, which can cause a myriad of symptoms, but the most critical one is going to be neurological dysfunction and kidney dysfunction, which can ultimately be fatal. Another example would be Guillain-Barré syndrome, which is an antibody-mediated disease with ascending paralysis, can also be fatal. And in this one, though, we don't need to replace with plasma because we actually don't need to replace the von Willebrand factor multimers that I mentioned for the first disease. And so for that one, for example, we can replace with 5% albumin, which for the purposes of the device is easier. And so that one we can replace, and that one would be something where we would do every other day, whereas to go back to TTP, that would be daily until they're improved. All right, so where did apheresis come from? Well, they were actually inspired by cream separators. So back in the 1870s, there was the development of the cream separator, which was a hand-cranked continuous centrifugation. Before this, you used to milk your cow and you would just set the milk out. You have to let it sit overnight and then the cream would rise to the top on its own. But the cream separator actually was able to help speed up this process. And so then from the 1870s, we don't have a lot of progress until the 1940s and 1950s, when we started being able to started developing fractionated products from blood itself. So we were able to develop the isolation of serum albumin fraction from plasma and the separation of other blood components. That was the beginning of the separation of blood components practice that we are so familiar with today. And I believe the first actual therapeutic plasma exchange was in 1954. And so then as we progress, we continue to use the advances in technology to be able to improve our medical treatments. So for example, we were able to bring in computer automation. And as of today, we have a highly automated system, which still does need an operator to do all of the fine tuning, but it does have quite a bit of assistance for us. So as I was saying, apheresis separates whole blood into its separate components. We have it because of the centrifugation, the density of the different components ends up moving all the way to the outer side, right? Because we're spinning like this, not like this. And so it separates out to the outer components. So the red cells get compressed to the outside. The white blood cells end up in the center along with the platelets. And then the plasma is kind of at the top or center, depending on the orientation. And so that allows us to be very specific with the layer that we choose to remove. And when you start talking about things like emergency leukocytopheresis or, for example, CAR T collections, you can see that even the T cells and B cells separate out a little bit. So you can get pretty specific with the collection process. And so centrifugation apheresis, because there are some other methods out there. So we're going to primarily be talking about centrifugation apheresis because that's what we're most familiar with in the United States. And my understanding is that this particular device is predominantly used worldwide. There are other devices available. We're just not familiar with them. So that's why we're not going to talk about them today. And I also want to mention that there is filtration-based apheresis, which is the device that is predominantly used in conjunction with, for example, the CRRT or dialysis machines. Those are equally effective. They're just not as commonly used in apheresis as we know it here. So centrifugation apheresis allows us for the targeted removal of plasma from the patient, as I showed you on the previous slide. The patient is connected to apheresis via the machine via 2 intravenous lines, so we need an out and an in, right? There's a big continuous circuit. The blood is then incrementally removed, centrifuged, the desired layer, in this case plasma, is removed and then replaced with, as I said, albumin or plasma from blood donors. And then we'll typically remove 1 plasma volume, which is the total blood volume minus the hematocrit each treatment. Sometimes we'll adjust that. Like I like to do 1.5 for the first treatment and then 1 after that. And then treatment is daily or every other day, depending on the disease process and what we're targeting. And then other methods are available or more commonly used in other settings, as I was saying, filtration-based apheresis as an example. We also don't have a lot of the columns, the immune-based columns here in the United States, but I do know internationally those are more available. And one final point I want to make before we kind of get into the particulars of this study that we want to talk about is one of the key reasons why these questions for the study even came about, which is what are some of the impacts on the patient as we do this procedure? And one of the main ones is going to be the impact on coagulation factors. So if you were replacing with albumin, 5% albumin instead of plasma, right? If you're replacing with plasma, this is a moot point because you're just replacing with the equivalent number of factors. However, if you're replacing with albumin, you're going to see an immediate decrease in the various coagulation factors. For example, you can see here that the majority of them are going to drop anywhere from 50% to 30%. The vast majority of them don't drop below 30%, which is generally believed to be adequate to maintain hemostasis, so we don't usually have to worry about sudden bleeding. But the one that we want to be careful of is fibrinogen. Fibrinogen doesn't have the rebound that the other factors do. So you can see here, 24 hours after plasma exchange, almost all of them have returned to baseline or near baseline. 48 hours, pretty much all of them are within baseline. However, fibrinogen drops to about 60%, or can drop to 50 to 78% immediately after the procedure, and then usually only returns to about 60% 24 hours. And it's slow. It doesn't tend to resolve as quickly as the rest of the coagulation factors. So some people bounce back great and some people don't. So that's one that we have to keep an eye on as we think about what we're going to do for plasma exchange and whether or not a patient needs replacement. Patients who have a high risk of bleeding, have liver disease or other problems, may need to have FFP as replacement or have FFP replaced afterwards because, for example, someone with liver disease, their coagulation factors are already very low or potentially even non-existent depending on the severity of their liver disease. So you may be going in at a severe deficit to start with. And then I also want to mention some of the lab values that you'll see immediately after plasma exchange. So you will usually see a small prolongation in PT and PTT. It's nothing to worry about because it will rebound quickly. A key factor is that you will generally see a reduction of circulating platelets, and this can vary widely. It can be anywhere from around 10% to more than 50%. And platelets also typically resolve in 48 to 96 hours. Sorry, I have an automated timer in my office and it has just decided that I am not here. So I'm trying to get it to turn back on. And then it will also impact other laboratory values. So whenever I have a critically ill patient, for example, in the PICU, they, for example, to go back to TTP, they have TTP, they have an elevated LDH. We come in, we do the plasma exchange, and what will inevitably happen is the physician will draw the labs immediately after that plasma exchange. And they'll be like, oh, their numbers are great. They're getting cured. I'm like, no. We just took those out, right? You need to watch for the rate of rise. I always recommend not doing the labs for about 12 hours to try to look at how quickly they're rebounding as opposed to what the actual level is, because that's going to be an artifact. Okay, so let's talk a little bit about why we decided to do this study, and hopefully you have some inkling with everything I just went through. So there are no transfusion guidelines specifically for therapeutic apheresis. There's lots of transfusion guidelines out there for various other issues, but none specifically for management around therapeutic apheresis. There have been some recently updated international transfusion guidelines. However, those did not mention therapeutic apheresis. And then bleeding risk in therapeutic apheresis is multifactorial. It may be because we are further decreasing their coagulation factors. They may be coming in predisposed to bleeding. It may be dependent on what kind of line they need for access, etc. And then so what ultimately happened was the ABB therapeutic apheresis subsection decided that we wanted to see if there were any patterns or trends, kind of a internally developed or kind of practice developed set of guidelines that we were kind of all using but that hadn't been made official, and try to look at those as a starting point for the potential development of a standardized set of guidelines. And so with that, I'm going to turn it over to Dr. Cohn-Sullivan to talk about the survey design and distribution.
Lovely. Well, again, thank you to Tanya for inviting us here. Thank you all for having us. And Kyle, thanks for that lovely introduction. Excuse my bit of background noise. I am in a house as a guest, and so the dogs are not mine, but they're very lovely. So if you hear a bit of background noise, that's what it is. As Kyle was suggesting, since there is little formal guidance for how to transfuse patients before, during, and immediately after therapeutic apheresis, and because that's often a point of logistic contention or disagreement, different groups want to do apheresis more quickly versus other groups want to transfuse up front to have more optimized lab values before therapeutic apheresis. We hoped to just do an international survey, ideally to get enough information to have a reasonable understanding of what a variety of different practitioners in different practices actually do. So our goal was sort of one and done, do the survey, understand what people are doing, and then perhaps develop some guidelines ourselves. Now, for any of you who have performed a survey for academic data gathering, you probably well recognize that sufficient response rate is a challenge. And that will come up in just a moment. So we did our best to design a very brief, succinct, pointed survey. We designed it, we beta tested it to optimize the question clarity, to make sure that the questions were readable, understandable, and probing the right information. With the goal of sort of optimal or best survey practice, we calculated a sample size for a 95% confidence level and an appropriate margin of error for the number of people we planned to distribute the survey to. And the survey was distributed to almost 500 members, all of the members of the AABB Therapeutic Apheresis subsection. The value of sending it to this group of practitioners and providers is this is an international group representing people performing apheresis in a variety of different settings. And we hoped that the participants would be in high proportion, people who did apheresis and who thought about it and cared about it. We also sent reminder emails and told the people receiving the survey if they wanted to redistribute to other practitioners, that was allowed and that was permitted. All right, next slide. So this is the breakdown of respondents to the survey. You'll see toward the bottom of the slide, the number of responses was 47. So this did not meet our calculated sample size for that desired confidence interval. The sample size needed was 80. So this was a little bit disappointing, but we will discuss next steps from that in a moment. You'll see a large proportion of respondents were academic clinicians, followed by those in blood centers, such as many of you, or community centers. A majority of providers responding were transfusion medicine practitioners, followed by hematology and other. And most respondents treated both adult and pediatric patients with apheresis, and a smaller number treated only one or the other.
Right, so I'm going to take back over for a few minutes. So next we're going to talk about our next steps, which was since we didn't achieve our goal for the confidence interval, and then the responses that we got actually surprised us to some extent. We're going to talk about that a little bit. We decided that the next step would actually be to develop focus groups and kind of delve deeper into some of these questions. So Dr. Cohn-Sullivan and I, in partnership with the Therapeutic Apheresis subcommittee, developed a focus group proposal for the AABB annual meeting last year in 2024. And what we ended up doing was we had a session where everyone came in, everyone sat at round tables. We had a facilitator at each table. And then we asked a series of questions that kind of followed up on these survey results in order to kind of delve a little bit further and get some perspectives on why some of those answers might have been chosen the way they were. Unfortunately, of course, AABB did accept this focus group survey. It was actually very well attended. I think we had over 100 people show up. I don't know the exact number, but it was very well attended. And so we thought we got some really strong results. So for this particular session, we did make sure that we had appropriate ethical oversight. So the Institutional Review Board determined this to be exempt. As everyone came in, because we did plan to turn this into a manuscript and we were actually recording all of the tables in order to be able to analyze results later, we did essentially say, if you stay in the room, you are therefore agreeing to participate. We were very clear about that. It was on the slide. We announced it several times. It was like, if you don't want to be recorded, please leave. There's no way for us to sort you out later and say, oops, we're removing your answers. The participants were divided into 8 groups, as I said, each led by a subject matter expert. And then we did actually have a demographic questionnaire. It was just little sheets at every table, and we did ask the facilitators to make sure that everyone answered those questions, just to have an idea as to who had showed up for this meeting. And then, as I said, we did actually record. We used AI. This was a fun one. We used a little AI recording device that automatically transcribed all of the discussion. And then our facilitators then edited the transcripts and sent it to myself and Dr. Cohn-Sullivan for further analysis. So our focus group demographics overall were pretty similar to the responses that we got from the survey. The majority of attendees, unsurprisingly, because the meeting was based in the United States, were from the United States, although we did have a handful of international attendees. The practice specialty was predominantly academic, followed by actually community, and then slightly lower than that is in percentage is blood center, with just a smidge of other. There were some people who came in from industry, for example, just to observe what we were talking about. We had a majority of specialty of transfusion medicine, and interestingly enough, followed by other as opposed to hematology. Maybe those guys were all going to ASH. And then we asked if they remembered if they had completed the survey. And I realize this is kind of a difficult question because if you're like me, I don't remember whether or not I did a survey a year ago, right? But we did try to see if anyone remembered that they had answered the survey. And so the majority of them said no, a significant proportion said unsure, and a few of them did distinctly remember answering the survey. And so of the total responses, we got 83 responses. Again, not everybody did fill out the survey or turn in their paper. So we got 83 responses, and 85 indicated they were currently in practice. And the reason for the difference in those numbers is that multiple responses were allowed, so some people checked multiple boxes. All right, so now we're going to move into talking about our actual questions and results. I'm going to hand it back over to Dr. Quinn-Sullivan.
Lovely. Thanks, Kyle. So the first topic or question of discussion that was gathered from interesting responses found in the survey and taken to this focus group was, at what platelet count threshold do you want patients, are you comfortable with patients when you are initiating therapeutic plasma exchange for TTP? All right, next slide. So you will see a number of our initial survey results here on the screen, and don't be overwhelmed. We'll zoom in just a moment. So on the initial survey distributed to the therapeutic apheresis subsection of AABB, we noted a patient needs the following procedure, and we asked about a variety of procedures. Select the platelet transfusion thresholds you would use for each example. So the far left column on your screen in the results shows a variety of different indications for therapeutic plasma exchange or other therapeutic apheresis procedures. And then the top row shows different providers' preferred platelet threshold for initiating these procedures. So next, Kyle. For therapeutic plasma exchange for TTP, again, the sort of hallmark indication for therapeutic plasma exchange, as it is first-line treatment and life-saving, we noted some interesting responses, which is a reasonable proportion of clinicians were happy to provide therapeutic plasma exchange, the first-line treatment for this disease, at any platelet count in patients. But a significant number of respondees of the survey said, well, I wouldn't want to start therapeutic plasma exchange in my patient unless their platelet count was 20,000 per microliter, 30,000, or even up to 50,000 per microliter. And that would be, so we were interested that interpreting the survey, it sounded like some practitioners would transfuse platelets to their patients before initiating therapeutic plasma exchange. And that did not align with Kyle's practice, my practice, or the majority of people in the work group's practice. So next pop-up. So almost half of respondents wanted platelets higher before initiating plasma exchange for TTP. Next slide. So we took that interesting result or unexpected result and took it to this focus group for discussion. We noted good practice statements from the International Society on Thrombosis and Hemostasis generally recommend not transfusing patients who are not bleeding with acute TTP because of the risk of thrombosis. We noted the survey results that we found interesting. Some of these respondents seemed to want platelets higher before initiating therapeutic plasma exchange for this indication. And we asked the group attending the session, would you ever choose a similar threshold? Please tell us why or why not. And we also asked, would you ever consider prophylactically transfusing platelets in this patient population for this indication to meet a platelet threshold? Next slide. So here is a summary of sort of interesting responses we received from the focus group discussion. Focus groups, of course, don't in general generate quantitative data. They are interesting for their qualitative data. So our goal with surveying this group of apheresis interested providers or majority providers was to generate interesting responses and to generate their view of the survey results. An initial interesting point was that pediatric institutions may be more conservative or may want to transfuse platelets more readily than some adult institutions, often regardless of diagnosis. Another thought was because the diagnosis of TTP is relatively more rare among pediatric patients than among adults, pediatric practitioners might be more likely to miss the diagnosis or take longer to come to that diagnosis and have transfused some platelets in the interim. Another, I thought, very pertinent note, the second down, was that standardized tools, different institutional guidelines, electronic medical record prompts, the AABB platelet transfusion guidelines, prescribe specific goals, but in general, I have not encountered any of these guidelines or prompts that are specific for the disease entity TTP, which is sort of a unique situation in that while platelets are very low, there is significant systemic inflammation and platelet activation and these big von Willebrand factor multimers that are allowing platelets to clump. So though platelets are low, the risk of thrombosis is high. So the note was a lot of our guidances do not take into account the pathophysiology of the specific disease. Other interesting notes were often when a consult comes my way or to the responding clinician's way, patients already have a central venous catheter. And at times, outside services placing central venous catheters have hard and fast thresholds for transfusion, so they may have already transfused platelets to place that CVC. Another interesting topic that came up that will come up over the course of all the questions we discussed today is this sort of internal hospital power dynamic question. And some respondents thought that hematologists often had more authority among the different teams discussing a patient's care than transfusion clinicians to determine whether a patient ought to receive platelets or not. So if hematologists in some situations thought transfusion was indicated, transfusion clinicians thought perhaps it's not, often this respondent felt often the hematologist's opinion or decision would win out. Other things are things that you ought to take into account in individual patients when considering risks and benefits, which is what were viscoelastic testing results saying? Did it look like the patient was had a coagulopathy? What fluid replacement was being chosen? Generally, here it is plasma, often 100%. Some people mix a little bit of albumin in, and the anticoagulant type that the platform providing apheresis used. And then also patient systemic anticoagulation ought to be considered. So we found these questions interesting and thought that those topics shone light on why there is no perhaps specific threshold in this patient population.
Tried to jump the gun on there. Sorry, Dr. Cohn-Sullivan.
Oh, no, not at all.
that brings us to our next topic. So the next question that we asked during the survey was about, again, platelet thresholds, but in this case, it was for central venous catheter placement, specifically excluding TTPs. The first question was about TTP because we were kind of stunned when we got these results, at least myself and Dr. Quinn-Sullivan, that anyone felt that, you know, they wouldn't start TTP or plasma exchange unless their threshold was at least 20, since our having been brought up with the idea or trained with the idea that you don't transfuse platelets and that you need to start plasma exchange immediately, and that they actually are very low bleeding risk in general, that we were very surprised by that. So this question was more specifically, what is your standard threshold for the other conditions for which you might do therapeutic plasma exchange, excluding TTP? So for this survey question, so again, this is the survey, an apheresis procedure had been requested and the patient had a platelet count lower than the selected threshold from the prior question. So if the clinical team felt the procedure is urgent. So in this particular case, we had this ranking and we said, how would you manage the thrombocytopenia? So rather than necessarily focusing on the platelet threshold, which was in the first question, right? You remember there was the big table and we had some other questions. So we had on the first table, it said, this is the percentage of people that would, just for general general therapeutic apheresis needs, we would do, you know, this is our guideline. This next question also focused a little bit on what you would do as far as proceeding with that urgent procedure. So would you, for example, just go ahead and do the procedure and then transfuse afterwards? Would you try to defer the procedure and give a simple platelet transfusion beforehand? Would you start the procedure but use platelets as your initial transfusion fluid, like your initial starting fluid in the machine? Which was something that a colleague had suggested during the development of the survey that I had never even heard of or thought of, to be perfectly honest. And so, or would you transfuse a platelet unit concomitantly through, for example, a PIV while you're running the procedure? So as you can see, there were quite a few different responses that were ranked. The strongest or most preferred was to either defer the procedure or concomitantly give the transfusion, or to initiate the procedure and then give it afterwards. Obviously, there's a lot of variability in this situation for this. It seemed that a lot of people also had not heard of doing the platelet fluid as the initial replacement fluid. So what we had in our survey results was that about 45%, again, almost half of our respondents, did say that in order to start the procedure, they would require platelets of between 30 to 100,000 in order to place the CVC in order to start plasma exchange. So this is not really generally in line with most data for platelet transfusion prior to CVC placement. So for our focus group question, we said that the Association for the Advancement of Blood and Biotherapies, AABB, suggests prophylactic platelet transfusion for patients with a platelet count of less than 20, requiring central line placement or CVC. And as I had already pointed out, about half of our respondents actually wanted a level of 30 or greater. And so our question to the group was, would you ever choose a similar threshold, 30 to 100,000? And if so, why or why not? And I do want to point out that this question was based on the prior guidelines from the AABB. The new platelet transfusion guidelines actually came out shortly after this focus group. So there wasn't a significant difference in this particular question, but I just want to point out that we were using the older guidelines. So for this focus group discussion, this one I think had less surprising answers. Generally, the respondents said they were very surprised by the survey response, that most felt that the AABB guidelines from 2015 were perfectly appropriate, and that's generally what they went with. This topic came up again. There were concerns about disagreement with the clinical team, that there's facility-specific guidelines that may not align with the AABB guidelines, that sometimes conflicted and tended to have the facility-specific guidelines win by default. There was influx of new providers that may have had a facility-specific guideline or learned something different from somewhere else, and they wanted to continue practicing the way they had been trained from wherever they had came from. And there were thresholds that varied by service. For example, surgery often wanted a threshold of 50,000, which is generally the threshold for surgery in general, for example, abdominal surgery, as opposed to a CVC placement, which is a different level of risk. Pediatric centers were noted that they may have higher thresholds. For example, it was stated that a paper from 2002 required platelets greater than 100,000 because there is a higher risk of seeding the CNS if the patient has suspected leukemia. If you do the first lumbar puncture with less than 100,000, that's not directly related to CVC, but in general, that's an example of some interesting literature digressions. And there's, of course, more recent literature actually disagrees with that particular point, so please don't take that one home. But the requirements tend to remain. I know at my facility here, actually, that's still something that everyone insists on practicing, even though there is literature since then to refute it. And then also operator experience and ultrasound use may also impact the risk and safety of placing a CVC, which makes a more highly experienced practitioner will have a lower risk of bleeding. Platelet refractoriness is a significant challenge to reaching a certain threshold. There was a fair amount of discussion about talking to providers about maybe not even being able to reach the 20,000 threshold, depending on platelet refractoriness or running a platelet drip during the placement. And then there was also discussion about the functionality of platelets, so not true immune-based platelet refractoriness, but dysfunctional platelets based on, someone is uremic, someone is on a platelet inhibitor, someone is on ECMO, etc. Those may impact the thresholds. So overall, people were in general surprised, but they felt that the differences in practice, despite well-established guidelines, 2015 is 10 years ago, seem to potentially account for the surprising result in the original survey. So as we wanted to note, we did base this on the 2015 guidelines, and in that one, the prophylactic transfusion for platelets was less than 20. Our updated guidelines in 2025 actually reduced the prophylactic transfusion for platelets to 10. So as long as it's at a compressible site, that transfusion threshold is now even lower.
All right, the third topic of discussion, generated from interesting survey results and taken to this group for discussion, was hemoglobin thresholds for red blood cell exchange. So we'll switch to the initial survey results. The question posed in the initial survey to ABB Therapeutic Apheresis subsection members was: patient needs red blood cell exchange, and what threshold hemoglobin level would you require before beginning that indicated procedure, right? And Kyle, you can select the appropriate data. Here, similarly, you can see the different entities we were asking the survey respondents on the far left-hand column. And then above the initial row on top, you see different levels of hemoglobin in grams per deciliter. So we asked, would you be comfortable beginning a red cell exchange at 6 grams per deciliter or lower, 7, 8, 9, 10, or greater than 10? Looking at the response, we were actually quite interested at the wide array of responses provided by those who answered this question. About a quarter of respondents were happy at 6 or less, basically any level. Some required 7, which is sort of similar to the red blood cell prophylactic transfusion thresholds that have stood for many years in a variety of indications. But swinging all the way over to the far right-hand column, a few respondents wanted their patients at a threshold hemoglobin of 10 grams per deciliter or greater before initiating a red blood cell exchange, which we found curious in that many patients receiving red cell exchange are receiving it for sickle cell anemia. And many patients with sickle cell anemia do not ever have a hemoglobin of 10 grams per deciliter or higher. So we found these responses interesting. Okay, next slide. So some 70%-ish of respondents wanted the hemoglobin between 7 and 9 grams per deciliter to begin a red cell exchange. Next slide. So we asked the discussion group at the AABB annual meeting, these are our results. Under what clinical circumstances would you choose a similar threshold? Is that where you would prefer your patients to be? And next we asked, if you are considering exchanging a patient with a hemoglobin, or would you consider exchanging a patient at lower than 7 grams per deciliter? Why or why not? If yes, under what clinical circumstances? Next slide. We found this generated sort of the discussion we expected, but we felt it was kind of necessary and pertinent. A number of respondents seemed to feel 7 grams per deciliter was a reasonable threshold. Another significant proportion felt that no specific threshold would be indicated, and really thresholds chosen patient by patient ought be guided by the individual patient's baseline hemoglobin, clinical status, acuity of the indication for apheresis, etc. Some, and I will say sort of from our analysis, some who had significant experience with red blood cell exchange, particularly in sickle cell disease, were willing to perform urgent exchanges for reasonable indications at very low hemoglobin levels. But others noted that some barriers to performing exchanges at these very low levels were our apheresis platform machine programming sort of vagaries. Sometimes the machines want baseline thresholds before requesting a special prime. Additionally, some noted that those operating the apheresis machine, commonly nurses in the United States, but not always, were variably comfortable with special primes, with priming the machine with red blood cells. And if nurses or those providing the apheresis were not comfortable, that would at times require simple transfusion up front. Others noted that the machine, when extracorporeal volume of the patient exceeds 10 to 15%, will often request the special prime. And others noted that when pre-procedure hematocrit is less than the patient's baseline, that might be a reasonable place to consider pre-red cell exchange transfusion. Reasonable clinical considerations were noted. So things that might make anemia more pathologic for patients, heart disease, frailty, or things that might make it us more willing to tolerate it, high acuity, needing a red cell exchange in the setting of an urgent or emergent precipitating event. And the one thing noted was a red blood cell prime, though not a common thing in a red blood cell exchange, but some noted the prime would expedite transfusion with, or rather expedite red cell exchange versus simple transfusion.
All right, so our next topic of discussion for this focus group was to talk a little bit about how to go in further into detail into that slide I had before, was after we've decided how we want, whether or not a patient needs prophylactic platelet transfusion, was to discuss how you would actually manage that. And so the previous question had been, what was your CVC threshold guideline? And then this one was actually to go into more detail about how you would do that. And so we had said in our initial survey, an apheresis procedure has been requested, and the patient has a platelet count lower than the goal that you want. The clinical team feels the procedure is urgent. Please rank your preferred method. And so, as I had said before, we have these 4 different kind of methods that you could potentially choose from. And the majority of the survey respondents, about 30% of each chose Transfusing post versus concurrently through a separate line. Slightly lower percentage chose to defer the procedure and get a platelet transfusion prior to starting. And as I had said before, almost no one chose initiating the procedure but used platelet unit as the initial replacement fluid. So for our discussion group topic, we went over this a little bit, and then the survey response, we mentioned that the survey responses on their preferred method of platelet administration varied widely. And we mentioned the majority responses in the original survey. So what we asked the group was, over the past year, which of the following methods have you used, meaning the attendees, to administer platelets when platelet transfusion and urgent apheresis are indicated? And we kind of gave them the list of options, and we asked them, what do you use most frequently, and what influences your selection of a particular method? So this one was a little bit all over the place. So the consensus was there's no absolute threshold platelet transfusion platelet count threshold in order to start. For stable non-bleeding patients, most thought that a minimum of 10,000 was appropriate. I will note that for the Optia device, and this was discussed, that the device does have minimum requirements itself. The device itself won't be able to tell what the platelet count is, but the recommendations for the Optia device does generally say you should not start a procedure with a platelet count threshold of less than 30,000. But that's not a hard and fast rule. So the discussion of the preferred time and method of platelet delivery generated a lot of colorful and varied options. Mostly pre or post procedure simple platelet transfusion was preferred over intra-procedure administration. And the benefits of post-transfusion were decided to be less than the intra-procedure platelet loss. So that felt that would balance out going ahead and starting the procedure and then giving a post-procedure transfusion. And there were a lot of details that were kind of discussed. For example, a pre-procedure platelet transfusion might take as little as 30 minutes. Hopefully they don't have an allergic reaction if you're dumping it in that fast. And thus unlikely to significantly delay the procedure, because that's about the amount of time it's going to take to set the kit up and get everything up and running. So in general, pre-procedure transfusion was favored, particularly in patients with platelet counts near 10,000. Whereas patients who had a slightly higher starting threshold, they preferred to do a post-procedure platelet transfusion. It was also noted, this again came up, that the platelet transfusion decisions were often made by clinical teams and not the apheresis consult service. If you remember, with the first two questions, it was commented that a lot of times the clinical team had made the decision to go ahead and place the line or do a platelet transfusion even before apheresis had been consulted. This was also true. Some actually had found fault with the question, saying that diagnosis commonly associated with thrombocytopenia and need for urgent apheresis were rare, and that perhaps most notably TTP, as was mentioned in our first question, platelet transfusion is basically contraindicated. And there were sites where and a few sites had two apheresis platforms available. For example, Optia, which is the one we've predominantly been focusing on, but then also the Amicus, which is by Fresenius. They would choose the device they preferred in the setting because they actually have different parameters for platelet safety between those two devices. I've never worked with the Amicus. This again is not to be a proponent for any particular device. It's just based on familiarity. So ultimately, this one was a little bit of very much of the patient's underlying clinical situation, the timing for the procedure, and what the particular device and facility requirements needed.
The last discussion topic we took from interesting survey results to this focus group was, what platelet thresholds or at what platelet count would you like your patients to be before performing therapeutic platelet pheresis? So this is a slightly different question in that platelet pheresis is often provided in patients with very, very high physiologic or pathophysiologic platelet counts. So the question wasn't, do these people need platelet transfusion before receiving this? It was, what clinical settings and platelet counts would lead you as a clinician to providing this, this procedure? So let's look at the survey results. So we asked the respondents of the survey, an adult patient has elevated platelets. The team wants platelet pheresis. At what thresholds or what thresholds would push you as a clinician to approve this procedure in different clinical settings? Again, on the far left-hand side, you see a variety of different sort of brief clinical vignettes, indications. An asymptomatic patient, a patient at risk of bleeding or clotting, a patient with active bleeding or clotting, and a patient with a high platelet count due to a reactive etiology because of sort of baseline elevated inflammatory state. Again, across the top, you'll see different platelet thresholds, 100,000, 500,000 on up. We were quite interested in the results of platelet pheresis for the risk of bleeding or clotting and those without symptoms. Half of providers wanted their patients at a platelet count of greater than 1 million or higher before performing therapeutic platelet pheresis. All right, so we took this topic to the discussion group. Next slide. One note before we get into the discussion group comments was we have a separate parallel project ongoing about this specific topic, therapeutic platelet pheresis, because it's something that comes up often, only rarely. Many institutions nationwide here in the United States don't perform it at all due to low comfort level or due to sort of too few patients requiring it for nurses to be adept in the procedure. So it seems like something many apheresis providers have a lower level of comfort with than many other indications, mostly because of its rarity. We noted in a separate survey of a number of data contributors who had performed this procedure that a lot of the patients who received therapeutic apheresis or platelet pheresis, a lot of times it was performed for symptomatic patients in some 85 or 86% of cases reported from a group of collaborators. And this is a breakdown of the symptoms treated patients had. A largest group of symptoms was neurologic, but non-seizure. Stroke was slightly smaller, then bleeding, and then thrombosis. So these are symptoms often prompting this procedure, at least among a group of some 10-ish collaborators in a separate project. Next slide. So the question we asked the focus group here was the National Comprehensive Cancer Network's guidelines for myeloproliferative neoplasms, often the entity causing extremely high platelet counts. Categorize therapeutic platelet pheresis for this indication as not first line, not second line, but useful in emergent situations. AKA one thing that they note is thrombosis-related neurologic complications. Again, the results we got was some half of providers responding to our survey thought a threshold of 1 or 1.5 million platelets, even in an asymptomatic patient, was enough to prompt this treatment. And we asked this group, would you choose a similar threshold, asymptomatic patients at these levels? Why or why not? Next slide. Responses we had from the focus group was, again, an initial sort of framing response. This is a procedure rarely offered, and even when offered at a specific institution, often rarely used. Many respondents agreed with this threshold of 1 million platelets per microliter, but noted it was a theoretical preference. It was something they were comfortable with, but if really pushed by a requesting, say, hematology team or other team, they would consider doing it particularly in symptomatic patients with lower counts. So for asymptomatic thrombocytosis, 1 and 2 million platelets per microliter were commonly stated thresholds to perform therapeutic platelet pheresis. Reasons that these respondents in the focus group thought that these were good levels were in essential thrombocythemia or other myeloproliferative neoplasms. Platelets are deemed pathologic and potentially hyperreactive and more likely to provoke both bleeding and clotting. Predicting the risk of these adverse events, bleeding and or clotting of the pathologic sort, was challenging. Sometimes the commonly used medical cytoreductive agents take a significant period of time for onset of action, so they can be provided, but patients often still have high platelet counts. And some respondents admitted they did not like the sort of social tension when another team was consulting them and the discomfort of saying, I don't think this is comfortable. I'm comfortable providing this procedure, though you want it. They wanted to avoid that tension and would often agree to this procedure, at least in part, to sort of keep the group happy. A number of people noted specific patient indications where, for one reason or another, it was appropriate or they felt it was appropriate to consider this treatment. One was a patient who was almost meeting inclusion criteria for a trial, but their platelet count was too high for inclusion, and that was sort of a single therapeutic available to them to treat their disease. Other respondents very reasonably requested or mentioned considering urgency, safety, and how the settings, inpatient versus outpatient, traveling, such as your models are, versus sort of in hospital, would impact comfort with providing the procedure. And some noted that failed medical management could be considered a prerequisite to initiate therapeutic platelet pheresis, but others felt that was not necessary as a prerequisite. So that was a discussion point too. Next slide.
All right, so we're finishing up here. I know we're at time. I do hope people can stick around to discuss and ask questions, because we would love to have your questions and feedback. So ultimately, when we looked through all of these results, we did note that there was quite a bit of variability in practice, which to some extent is the reason we started this entire set of questions and focus group, because there isn't a well-established threshold. And we thought maybe we'd find some similar trends, but it turns out that there's quite a few differences depending on whether or not guidelines are followed, whether or not there's different, training approaches, etc. There were a lot of challenges in decision making. There were discussions about platelet refractoriness, platelet shortages, equipment limitations, training, whether or not nurses were comfortable with, for example, performing a blood prime. Myself being in pediatrics, my nurses are very comfortable with a blood prime, but an adult facility might be much less familiar with doing that if it were needed, particularly with a red cell exchange, because that's a little bit of a tweak to the procedure. And this is one topic that came up over and over that really was very notable, which was that a lot of comments were made about feeling that their clinical judgment was overridden by the clinical team that was requesting the procedure, or in some cases demanding the procedure. There were some pretty strong statements among the discussion as far as feeling that they were unable to kind of stand up for their clinical judgment in the face of various other providers. And I do want to say that having been in the room, we didn't ask how many years of practice someone had been in for the survey. Maybe we should have. But for the focus group discussion, I can just tell you from having been in the room, and I'm sure Dr. Cohen-Sullivan can comment on this, that it did seem like it was the majority of attendees were probably on the earlier in practice side. So I don't know how much of this communication and judgment focus was just inexperience and not yet being comfortable for really standing up for yourself, maybe not feeling like you're in a position to stand up for yourself against a provider that had been, you know, in practice for 20 years or had, you know, much more clout. You know, or even whether or not administration is supportive of you standing up for yourself as opposed to what the surgeon who brings in all the money wants. I'm fortunate here where administration very much stands up for transfusion safety. And so if I say, you know, this is our practice because this is safe, this is regulatory, I do get support, but I know that that's not true for all hospitals. Some hospitals will say, well, the surgeon brings in a lot of money, or this particular area of the hospital brings in all the money, so just do what they want. And so I know that that can be an ongoing challenge. And then pediatric thresholds, pediatric centers, you know, may have different thresholds due to safety concerns, historical practices. And, you know, in the pediatric world, we are very often basing our clinical judgments and our literature on literature that is based on adults, right? The vast majority of research that we have is still lacking in pediatric focus. So sometimes we're just kind of extrapolating pediatrics into little adults as opposed to having their own unique physiology, which particularly neonates do. So those were essentially our findings from this survey. We didn't, you know, kind of reach our initial goal, which was maybe we have some thresholds to define, but I think we still had a really interesting place to start for further discussion. So in conclusion, we do need to develop better collaboration, particularly between institutional groups and interdisciplinary, in order to make sure that we have standardized safe transfusion practices in the peri-apheresis area. We may want to develop better practice guidelines and tools, maybe have that EMR support be smart enough to say, hey, don't transfuse this patient because TTP is in the differential, something like that. You know, this is a mixed method research study, and it is qualitative data, as was mentioned. So we do have limitations like low response rate and regional focus, which is going to impact our generalizability. And so the answer that comes with almost every research project there is that, you know, more research is needed. We need more studies and more discussion to potentially further established, well-defined guidelines from which apheresis providers can start when trying to make some of these decisions. And with that, I would just like to, on behalf of myself and Dr. Cohn-Sullivan, I would like to thank everyone again for inviting us today. And I really look forward to all of your comments and questions.
Thank you so much, Drs. Annan and Cohn-Sullivan. That was really interesting. I know you gave your personal experiences from the United States as well as the international results, but I can tell you that it really mirrors the South African landscape of clinical apheresis. Yeah, so we also use centrifugation apheresis. And we have South African transfusion guidelines, which we look at and review every couple of years. The latest ones were recently published. And yeah, they also don't include, we didn't even think to include anything relating to guidelines for therapeutic apheresis. For me, I'm just wondering if your poor response rate in the questionnaire was actually, it's very difficult to answer these questions. And that's why maybe people didn't want to answer them, because there aren't guidelines, and then you sort of want to answer, and then you're like, but why do I choose that? No, well, it's really patient by patient, or you don't really know why you do it. You know, it's just your feeling or experience for why you would choose a certain threshold. And really, yeah, in different situations, or depending on the comorbidities or the acuity of the situations. So yeah, I see the time, we are running out, but really, if there's any comments or questions, please, we can unmute people. I see that there are a variety of people in the audience. So we have clinical hematologists, transfusion medicine specialists. We've got yeah, so we've got a mixture, and we're happy to take comments from anybody. There is a comment from Nomuso to say, thanks for the interesting talk. For providers who choose to give IVI calcium gluconate prophylaxis during TPE, likely not a lot, what is the AABB recommendations or guidance for how much to give? So that would be somebody with normal calcium levels before starting a TPE.
So that's an interesting question. I'm not aware of a specific recommendation or guidance for the appropriate dosing. I know there's a variety of practice. It depends a little bit on the size of the patient and the starting ionized calcium level. Now, because I'm in pediatrics, we actually prophylactically give calcium gluconate for every patient. And so our starting dose is 25 milligrams per kilogram. I do know on the adult side, they do tend to, if the patient is starting with a low calcium level, or if they are particularly calcium sensitive rather than an IV drip during the procedure, they will often give a calcium bolus, and I believe that is a gram dose. I believe it's 1 to 2 grams of calcium, just given as a bolus, and that can either be prior to or during the procedure with a separate line, or it can also be given immediately into the return line for the patient. But that's a good question. I'm not aware of specific guidelines for dosing. Over the years, I've kind of developed an algorithm for how much to adjust the calcium based on the patient's response, and it's not always perfect, but I actually have an algorithm built into my order set that nurses can adjust based on the ionized calcium levels.
I think that is an interesting question, and I have treated adult patients predominantly, with a few peds patients sprinkled in at, I think, 5 different institutions in the US. Haven't spent a lot of that was in training, so I didn't spend a long time at each. But the practice here, like Kyle suggested, did vary a lot institution to institution. So some places I practiced provide the 1 gram, and it is provided sort of over the course of treatment. If patients are experiencing symptoms, that would be increased to 1.5 or 2. Where I am now, commonly a flow rate is prescribed for infusion concurrent with apheresis. But we also, in the US, recently ran into a normal saline shortage, which is used concurrently with calcium gluconate. And for that, patients at lower risk, some were switched to PO calcium, the medication Tums, that's commonly used for heartburn. So again, I haven't heard of guidelines, and the wide variation I have seen to me suggests that there are none.
Thank you. Any more questions or comments? I think people can unmute themselves if there is anything. Maybe just from my side, if I could ask something. So with this apheresis model that's decentralized, or a mobile service where there's the in-hospital clinicians looking after the patients who actually see the patients, and make the decisions that they want to phone you for the therapeutic apheresis, and then the therapeutic apheresis service, which is like external to them. How do you manage that apheresis, the transfusion guidelines around that, where there's 2 different teams, And again, as you said in your talk, that not really conflict, but there's, if you've got a TTP patient in front of you hemolyzing, you need to plex that patient. That's the only way they're going to survive. But then if you've got a patient with an HB of 5 and you're removing 15% of their blood volume, you want to get that HB up. So it's that, that balance.
I mean, that's an interesting point, considering sort of the increased need for coordination among outside of hospital, or an external blood service, a mobile service, versus inside. I suppose it would be useful to have guidelines address how patients should be evaluated pre, mid, and post, or pre, during, and post, because you may inherit the patient at different stages of treatment. Kyle, what were you going to say?
I was going to say that, kind of to echo what you said, and I realize this is quite the challenge because you have all different facilities that you're going to be going to. So maybe this would be more of a document or guideline that could be provided by the apheresis physician as to, kind of what steps are needed from the clinical team prior to coming in. And what considerations may be needed, such as platelet count, transfusion threshold, transfusion or hemoglobin level, CVC versus PIVs, et cetera. I will say that this is not remotely the same, but here, when I first started, it often felt like the team either forgot that we existed, or would basically try to do everything themselves and then call us and say, okay, show up for apheresis. We placed the line and everything. And we would be like, excuse me, what? So I think we've had to work with those teams a lot. And we did actually develop an internal document that was kind of a like initiating apheresis guideline for the residents to follow. And we also have clinical guidelines that are available. So hopefully with these internal kind of practice guidelines, you know, it has a whole flow sheet and everything. This is the point where you would call us, for example, for leukodepletion, which we actually don't offer anymore, but, you know, for a little while. Those were the components where we could hopefully get some pre-preparation prior to us showing up. And then clearly, I think that, you know, we would all agree that just good communication between the ordering provider and the requesting physician, having that conversation and saying, this is what I need you to do, this is what we'll do, this is what the expectations are on our side, and these are the expectations on your side, to help get everything hopefully running smoothly.
Great, thank you. Yeah, I know when we were audited by JC, they actually asked us for the document that we have as a apheresis provider for thresholds for starting procedures, even though you don't have to hold by those thresholds, but you need to have almost guidelines to say, in the ideal world, this is the HB that we want before we start the stem cell collection, or so, okay, great. Thank you. This was really interesting and valuable to us. And I know more research is the answer, but we are happy to assist with that research. Yeah, down in South Africa with different experiences and challenges. Yeah. So thank you so much for both of your time. I know you've got a whole day ahead of you. So thank you, really. Thank you for sharing your expertise. It's greatly appreciated.
Thanks for having us. And Tanya, thank you for your collaboration and for bringing South Africa's perspective to this project. It's really invaluable.
It's my pleasure.
Yeah.
Thanks. Good night, everybody. Good evening. Thank you. And good morning to the two of you. Thank you, everybody. Bye-bye.